Okay, thank you so much for having me. I'm so excited to be talking to everyone today. My name's Kristen Crichton. I'm a child abuse pediatrician in Columbus, Ohio, and have the pleasure of working with Amina. Today I'm going to talk about identifying child abuse in infants. As we know, this can be a particularly challenging population to recognize these injuries in. So my objectives today are to describe the epidemiology of child maltreatment and the risk of recurrent episodes of abuse, to talk about ways to improve detection of signs and symptoms of child maltreatment in infants, and to understand the approach to evaluating children with suspected physical abuse. So I'll start with a case example. This is a baby that I took care of when I was a fellow during my fellowship here. So he presented to the PCP initially at 2 months of age, and was noted to have bruising of his arms, legs, and subconjunctival hemorrhage. There was concern that maybe this was indicative of a bleeding disorder, so the PCP ordered a CBC and coagulation studies, and then saw the patient back in a week, at which point there was noted to be bruising of the abdomen. The initial screening labs for bleeding disorder come back normal, so the child was referred to hematology for additional evaluation for bleeding disorder. In the meantime, he presented to an urgent care with injury to the tip of his tongue. At this point, he's 3 months old. He does not have any teeth. So this is a concerning injury, but unfortunately, it was not recognized as such. And his fourth encounter was in our emergency department, where he presented with altered mental status and was found to have subdural hemorrhage, and a classic metaphyseal lesion, or fracture of the right distal tibia. So these injuries, of course, are very concerning for abusive head trauma and physical abuse. And if we look back, each of these encounters was an opportunity for us to recognize that this young infant really shouldn't have these bruises or the intraoral injury, and these were all opportunities that we could have intervened to protect him from the abusive head trauma and the fracture that he experienced. And we know that when we look at the literature, that morbidity and mortality does increase with recurrent child abuse. So here's another case example. This is a 3-month-old who came in with linear patterned bruises to his left arm, left forearm, and left flank. And then on skeletal survey, had multiple rib fractures. And when we took a history, the mom reported that the child was an easy bruiser. This is a 3-month-old, so we would not expect any bruises in this child. So easy bruising is concerning, and had had 3 to 4 nosebleeds over the last 2 weeks. And of course, nosebleeds are very common in older children when they're sticking things in their nose, like their fingers. But we don't expect any kind of nosebleeds in a 3-month-old. They're not picking their nose and causing those nosebleeds themselves. So that these were opportunities to intervene, because the mom did describe presenting to her pediatrician with these concerns, and we could have protected that child from those rib fractures. This is a 6-month-old that had bruising to both sides of his jaw. It's a little bit subtle here, but you can see it on the left side and right side, both sides of the jaw. There's submandibular bruising, and um, on additionally, this child had a fourth-degree burn of their left leg that ultimately required amputation of the leg. This child had been seen by a pediatrician 1 month prior with bruising to his buttocks and left leg. So in this case, recognizing that this child had bruising that he should not have, he cannot cause this accidentally himself. He's only 5 months old at the time, could have potentially saved this child's leg. So there's lots of cases, and they're sad and distressing, but these are opportunities to intervene to protect these children. When we look at the literature, we know that this bears out widely, not just at our hospital. So in a article, a kind of a Sentinel article from 25 years ago now, Carol Jenny reported on 54 cases of abusive head injury that were missed upon the first presentation. Almost a third of those kids went on to be re-injured after the misdiagnosis, and almost half of them experienced complications related to the misdiagnosis. 4 of the kids died what would have been preventable deaths if we had been able to identify that there was concern for maltreatment in these children when they initially presented. And while these data are old, a much more recent study shows very similar numbers. So a multi-center study evaluating children with abusive head trauma who had prior opportunities to detect abuse. 25% had at least one opportunity to identify abuse in a medical setting. 6% had an opportunity to identify abuse through Child Protective Services, which is our state government funded protective services for children with concerns for maltreatment. And in these groups of children, vomiting and bruising were the most common symptoms, which of course are not very specific, especially vomiting. But bruising, again, really shouldn't be occurring on these young infants. So what we're going to focus on now are these sentinel injuries. So this is defined as a visible or detectable minor injury. So these are going to be small bruises, intraoral injuries that don't require medical intervention for them to heal, but do require intervention in order to protect these children from developing or incurring future injury like abusive head trauma or fractures. The two most common types of sentinel injuries, like I said, are bruising and intraoral injury. When Lynn Sheets, who's a child abuse pediatrician here in the States, looked at the prevalence of sentinel injuries in children who ultimately went on to have worse abusive injury, 2/3 of those sentinel injuries occurred in children less than 3 months of age. So very, very young children, and almost all of them were before 7 months of age. Medical providers were aware of these sentinel injuries in nearly half of the cases. So there really is opportunity to intervene to protect these children. And this is a little bit of a complicated study, but what I want to show you is this study is looking at the recurrent abuse and how long it is between the first episode and the second episode. And that's the bottom darkest line. That's a slow arc. 25% of children had a second episode of abuse within the first year. And then the next line is the time between the second and the third episode, third and fourth, fourth and fifth. And what you'll see is every time a child's abused, they're more likely to be re-abused faster. So we have to intervene in order to protect these children. And intervention isn't going to look like putting a cast on it or examining for other underlying bleeding disorders. It's going to look like involving your partner agencies, the Child Protective Services, and law enforcement to make sure that these kids are in safe environments. While child abuse is really specific to where you practice, because of the partner agency involvement that's required with CPS and law enforcement, I did look to the literature to see what I could learn about the prevalence of child maltreatment in your area of the world. And this is a study from 2019, so a little bit old, but it was a survey of children that was done. These are school age kids that was done in each of these areas. So Albania, Bosnia, Herzegovina, Bulgaria, Croatia, and so on. Looking at different types of exposure. And I know there's a lot of numbers on this slide, and I can certainly cite the paper. But they broke it down between psychological violence, physical violence, sexual violence, contact with sexual violence, so exposure to sexual violence of others, feeling of neglect, and then positive and nonviolent parenting, which of course we hope there's lots of. And many of the kids reported that. And they looked at lifetime experience and then past year. And so this table is from lifetime experience. This is the row that is specific to Bosnia and Herzegovina, and I'm highlighting that row here. And when we look just at physical violence, which is those second columns, hopefully you can see a little bit bigger, almost 2/3 of the children reported some occurrence of physical violence in their lifetime. This isn't necessarily abuse because it captures all different kinds of physical violence that they may have been exposed to, and certainly not all physical violence is child abuse. But it is clearly something that is being experienced by children in their environments there. So to go back to those sentinel injuries, bruising is the most common type of injury in abused children. It's, of course, the most common type of injury in non-abused children. We see lots of bruises and lots of kids. So how can we differentiate? How do we know when to be worried? The first thing we want to think about is, what is the child able to do? So children are going to develop at different rates, and not every 4 month old or 6 month old or 9 month old has the same ambulatory capacity. So we need to understand what they're doing ambulation wise, because we know that as kids become more ambulatory, can move themselves more, the prevalence of bruises goes up. These are two studies that looked at the prevalence of bruises between pre-cruisers, so kids that are not pulling to stand. These are typically children younger than 9 months old. And then cruisers, so kids that are pulling to stand, and walkers, kids that are ambulating by themselves. And you can see here 2% of children that are not yet pulling to stand had bruises, and it goes up from there as children become more ambulatory and of course have accidental falls. Same thing in a similar study that looked at sitting, crawling, and walking. When we look at the metadata for bruising and age, children that are less than 6 months old, really less than 1% of them have bruises. As we get to 6 to 12 months and they're starting to crawl, pull to stand, walk, 10 to 12% have bruises. And then once kids are, you know, preschool years, running, jumping, falling off of things. I have a 6-year-old. Her legs, her shins are covered in bruises. We're going to see accidental bruises. So we really are concerned about bruises in these youngest children that really can't ambulate. When we look at the occurrence of occult injury, so injury that is not apparent on exam in these young infants, this was a study that was done in 146 children who are less than 6 months old with only one bruise noted on exam. So these kids come in, no signs or symptoms that are specifically concerning for abuse other than one bruise in children less than 6 months. These kids had all of the recommended imaging done, skeletal surveys to look for fractures, neuroimaging, either head CT or MRI, screening for abdominal trauma, and then an estimate of the likelihood of abuse was done. They also screened for bleeding disorders in all of these children. Of these, almost a quarter had some type of fracture identified on their skeletal survey. Over a quarter had some kind of injury, intracranial injury identified on neuroimaging, and about 3% had abdominal injury. Overall, 50% of these children had at least one additional serious injury that was identified by this testing that was not apparent through any other exam, and a high perceived likelihood of abuse. No bleeding disorders were identified. So we know that when these kids come in with a single isolated bruise, we're going to find other injuries if we look for them. Some red flags in the histories that we get for infants with bruising, so things that we hear from families. He laid on something. We'll hear that kids lay on pacifiers or toys that cause bruises, and that's not going to happen. That's not physiologically possible for laying on an object to cause bruising in an otherwise healthy child. She must have fallen against the side of the crib. We hear a lot about how cribs are very dangerous for children from our families, and that's just not true. That's not accurate. As long as they're in a safe sleeping space, they should not incur injury from the crib. His brother probably did it. While certainly older siblings can injure younger siblings, it's not going to be a serious injury, and we're not going to blame the 3-year-old without exploring other potential causes for the injury. She hits herself in the face. Young children aren't able to generate the force required to cause a significant injury by hitting themselves. And a toy fell on him. Again, that's not, unless it's falling from the sky, it's not going to have enough force to cause these injuries. So in these young infants with bruises, any bruise is concerning. As kids get older and they start running around and they become my 6-year-old who's a maniac and jumps off of everything and has bruises, now we want to think about where the bruises are. So bruising and location. And this is kind of a map. On the left is the accidental bruising. So forehead, chins, elbows, knees, shins, all those bony prominences where we know a hit to the shin is going to cause those capillaries that are underneath the skin there and trapped between whatever the child is landing on and their bone. They're going to break, and that's going to cause a bruise. We expect to see bruises there. Where we don't expect to see bruises are the softer areas. So around their eyes, ears, and we're going to talk more about ears, neck. You really can't fall on your neck. That submandibular area underneath that jaw, like I showed you in the case example, and then the abdominal wall, there's no bony prominences in our abdominal wall. We don't expect to see bruising there. And then buttocks and genitalia, of course, are protected areas where we should not see bruising without a specific history. So here's the same information, just in word form: accidental, forehead, chins, elbows, knees, shins; non-accidental, ears, neck, abdomen, buttocks, genitalia. So just looking more specifically, pinna or ear bruising can be the result of a blow to the side of the head or pinching and pulling on the ear. It's very hard for infants to fall on their ear. That's not going to happen. They have big heads and they're going to land on that the parietal part of their skull. They're not going to land on their ear. Older children, if you get a specific history of she rolled out of bed and hit her ear on the bedside table next to the bed, yes, that's plausible. But young infants really cannot do anything to cause bruising to themselves. Of course, the ear is on the side of their head. So if we see ear bruising, we want to think about doing imaging to look for intracranial injury, because we can definitely see co-occurrence of ear bruising with subdural hemorrhage. It's also important to note that you can see ear bruising to the back of the ear and that posterior auricular area without seeing bruising to the front of the ear. So it's important that when you're doing your thorough skin exam, you reflect the ear and look at the back of the ear to see if there's any bruising there. Scalp bruising, this is an example of a very large subgaleal hemorrhage. So the subgaleal space, the space between the scalp and the skull, is a large potential space. And children can develop significant anemia if there is the subgaleal hemorrhage. It often happens from traumatic hair pulling, it will be exquisitely tender. These children will complain of a lot of pain, but we want to make sure we're looking under their hairline to look for any injuries. There is a mnemonic that was developed by a child abuse pediatrician in Chicago, she's an emergency medicine physician, but she does a lot of research in child abuse, Mary Clyde Pierce. Pen 4 faces P, to help kind of remember when we should be concerned about bruises. The 10 is an acronym standing for torso, ears, and neck. We should not see bruises there on children who are 4 and younger. And faces is frenulum, so intraoral injury, angle of the jaw, cheek, eyelids, and subconjunctiva. And the 4 is any bruising in children 4 months and younger. And then P is for patterned bruises, which we're going to talk about. This clinical decision rule has been validated, and it is very sensitive and specific for picking up abuse. So if a child has bruises in these areas that meets these age requirements, that it is very important that we look for other injuries and think about abuse in these children. Patterned bruises, we can see slap marks. So when a child is hit, the capillaries around the fingers will rupture and you get an outline of the hand. We can see injuries with flexible objects. So if a child's hit with a cord or a cable, that cord or cable will bend around the convexity of the body and leave these patterned loop marks on the child. And then pattern bruising to the buttocks, because of the convexity of the buttocks. When there is a spanking or hitting to the buttocks, you can get these vertical lines along the gluteal cleft that results in those petechiae there. One of the things, of course, we want to think about is corporal punishment or physical discipline. Spanking, it has lots of names. In the US, it is legal to spank children, but it should be limited to buttocks or over clothing. And it should not leave a permanent mark. It shouldn't leave bruising. It shouldn't leave any kind of injury. US law isn't clear about hitting with objects. It says use of any object other than the hand has potential for serious harm, and acts of serious violence should be seen as abusive. I think it's important to understand where you're practicing what the laws are around corporal punishment. I was looking it up, and I understand that corporal punishment is also legal in Bosnia, although it is not legal in schools there. And in the US, there are still some states that allow it in schools. So you're doing better than we are in terms of getting it out of schools. But if our policy here is if it leaves bruises, that's abusive. That's not appropriate physical discipline, and we do engage our partner agencies. One quick note about dating bruises. I think I see a lot of documentation about, oh, I'm worried about this child because they have old and new bruises. And really, the science tells us we can't date bruises by color. There used to be thinking that, yellowish, greenish bruises are old and red, purple are newer, and that there's really no scientific validity to for us to be able to date bruises, even on the same child. There's lots of things that go into what a bruise looks like and how long it takes for them to appear and then to resolve, including the where the child is injured, the attachment of that tissue, the thickness of the tissue, the depth of the injuring force, the underlying color of the patient's skin, the age of the patient, if they have another medical condition. I also think that there's a lot of variability in what providers see, where we perceive color differently. And so at this point, there's really no scientific evidence to support dating bruises by color. I would just caution against doing that, even though we know it would be helpful to say, like, oh, this kid's been abused multiple times. The science just isn't there to back that up. One common mimic that we see a lot here is congenital dermal melanocytosis. It's also known as Mongolian spots. This is a common abusive bruising mimic. They're typically seen over the lower back and buttocks. That's what all of the textbooks describe. But we see them commonly over shoulders, wrists, ankles, and they're going to be different than bruises in that they're that homogeneous color, that slate gray, with a smooth border, and they're not going to resolve over time. And these can be seen in children of any complexion. They're more typically seen in children with darker skin, but really we can see them in children with any complexion. One of the things we always want to think about, is there an underlying bleeding disorder that's causing the child to bruise? So we think about coagulopathy, but it's important to remember that bleeding disorders are statistically much less common than child abuse. And many children with bruises don't really require a big workup for coagulopathy if they have another type of injury. So if you identify that a child also has rib fractures and bruises, the coagulopathy wouldn't cause a rib fracture. So that's not a unifying diagnosis. If there's patterned injury, if the child discloses or someone else witnesses the abuse, we don't need to do a big workup. The workup that's recommended by the American Academy of Pediatrics is the CBC, COAGS, von Willebrand panel screening for factor 8 and 9 levels. And we want to do this at the same time as we're making sure that we're keeping the child safe, because we know that some of these labs can take a while to get back. So we don't want to wait for them to come back to intervene to keep the child safe. Intraoral injury, I'll touch on briefly. There's 3 frenula. We have the upper labial frenula, lower labial frenula, so that thin rim of tissue that attaches the upper lip and lower lip to the gum line, and then the lingual frenula, so right under the tongue. These are injured accidentally all the time in young children if they fall and hit their face. But again, these are ambulatory children that are able to fall. In young, and there's examples of frenulum tears in young infants that aren't able to cause the injuries themselves. They can happen because of a slap or punch to the face, happen because of forced feeding, so someone jamming a pacifier or a spoon in the child's mouth. You can imagine an angry or a frustrated caregiver and a screaming baby kind of jamming something in the child's mouth. We can also see it with forced oral sex, is amongst the differential. Few other injuries I'll touch on very briefly. Subconjunctival hemorrhages are caused by increased intrathoracic pressure or a direct blow to the eye. They can also be indicative of an underlying infectious process. There are no hematologic processes that present just as subconjunctivals. And we know that when we look for occult injuries in young infants that present with these, we often find fractures, especially rib fractures that happen because of anterior posterior compression or squeezing of the chest that causes that increased thoracic pressure to go up. So even in children with an isolated subconjunctival hemorrhage, we do recommend doing the evaluation for non-accidental trauma. Now, birth also causes subconjunctival. So if it's in that first 2 to 3 weeks after birth, I would not be concerned about abuse, as long as we know that that subconjunctival has been present since the baby was born. Fractures and burns in young infants, of course, are going to be concerning. With a burn, we want to make sure we're getting a good history of what caused the burn. Certainly, things are spilled on babies, but they can't burn themselves. And then fractures, especially, are concerning. The workup that we recommend for all ages of children is a thorough undress physical exam. We want to look behind the ears. We want to look in the mouth. We want to look at their buttocks. For all children less than and equal to 6 months, we want to get the head CT or MRI. An ultrasound is not appropriate for these babies. Even though that fontanelle is open, the ultrasound probe only looks straight down. We can't see under the convexities or the curvature of the skull, and that is where the subdural hemorrhages happen. So we want to make sure we're getting either head CT or MRI, depending on what's available. The skeletal survey, which we'll talk about more, is recommended for all children under 2 with concerns for abuse. And then screening labs for abdominal trauma, AST, ALT, and lipase. If the AST or ALT are above 80, or if the lipase is above 100, we recommend getting the abdominal CT. Again, not ultrasound. An ultrasound is not sensitive to detect the injuries that we're looking for when we're concerned for abuse. A skeletal survey is not a babygram. It's 24 separate radiographic exposures, and this is as defined by the AAP and the American College of Radiologists. These are the images that are recommended by the American College of Radiology. So it's AP and lateral views of every part of the body, and the importantly, the oblique views of the ribs. So we want to make sure that we're looking at the ribs from the side to make sure we're not missing any of those rib fractures. There are lots of accidental fractures that happen with children, clavicle fractures, femur fractures, even with young kids. If you have the right history for it, can happen. Supracondylar fractures are very common accidentally in ambulatory children. Fractures that are concerning for abuse are listed on the left. The classic metaphyseal lesion, also known as bucket handle fracture or corner fracture, that's a fracture through the end of the long bone. So humerus, radius ulna, tib fib, and femur, that happens as a result of pulling and twisting on the extremity, or if the child is being shaken and their arms and legs are kind of flailing, you get that shear injury at the end of those bones. Posterior rib fractures are concerning for that anterior posterior compression. Scapula and sternum fractures are concerning because those are really big bones that are hard to break. Multiple fractures in various stages of healing. We can't date bruises, but we can date fractures somewhat, and we can see if there's old and new fractures, and that would be concerning. And then long bone fractures in non-ambulatory infants are also concerning for abuse. When we're thinking about when we're worried about abuse, we want to make sure that we're acknowledging our bias. Bias exists in everything we do in medicine. And if the more aware of it we can be, the more likely we are to make accurate diagnoses. We know we miss abusive head trauma more often in non-minoritized, higher income families, and we overscreen for abuse in minoritized families and children from low socioeconomic status. So we want to think as objectively as we can. And if there is a risk factor present, if there is a single mom or a young parent, that's fine, but that doesn't mean that the child has been abused. We want to think, does the injury we see on this child match the history that's being provided? And if it doesn't, then we want to be concerned. Even if they're the nicest family in the world, even if they look like they would never hurt their child, they're really rich, I don't care. We want to be as objective as possible, and always do the same approach for every child. This is the same slide I just presented a few slides ago, but I'm just to make it as routine as possible. When we see an injury that's concerning, we do the same workup. When we are concerned, we need to engage those partner agencies, so the Child Protective Services and or law enforcement, depending on your local policies. And we want to explain, why are we worried about the injury that we see? Does the history provided for the injury make sense? If not, why not? Here's some scripting. A 1-month-old infant is not capable of rolling off of a bed. This non-ambulatory 4-month-old can't cause these bruises to her legs. So to conclude, non-ambulatory infants, the presence of an intraoral injury or bruise should prompt consideration and workup for suspected child abuse. Many children are raised in environments where they're repeatedly exposed to harm. So catching these smaller minor injuries can save children's lives, because we know that recurrent abuse is associated with increased morbidity and mortality, and we don't want to miss the sentinel event as an opportunity to protect the child. All right, I was right at 30 minutes. Here's my child at a local football game, like for real football, soccer, as we call it here. And I'm happy to take any questions. And there's my email address, because I know we're running over time.
Thank you, Kristen.
Thank you. I'm happy to take any questions or people can email. I know we want to make
Yeah,
up some time.
sure. Any questions? No questions right now, but
All right.
we did do a recording, just FYI.
That's great.
Okay, thank you. We really
Thanks.
appreciate it. Say hi.
Bye-bye. Get out.
Bye.
There we go.